Thank you very much. Good morning, ladies and gentlemen. I'm Shingo Kasahara from Okayama, Japan. I'm very honored to be here and also give me a very difficult topic about the surgical strategy of DORB. Because of the DORB, the much variety there. Where is that BSD site? What side of the BSD? And also relationship of the greater arteries. The aiming to that biventricular repair or single ventricular repair. Very much varieties there. And then this one is DORB, the difficult situation about that the background of the interventricular rerouting, whether it's okay or not. Big interventricular rerouting patch inside the right ventricle. And then after that, right ventricle is made a little bit smallish. In such a situation, we cannot do that biventricular repair enoughly. And sometimes do that 1.5 repair, and also a tricuspid valve is a little bit small on the inflow side of the right ventricular inflow. And then transposition of the greater arteries and some occasion of that this combination, and the arterial switch procedure is much suitable for a repair of the DORB, subpulmonary BSE especially, the name is the forced taucipine. And also, usually to that right ventricular outflow tract narrowing, like a tetralogy of Fallot. And this one is much varieties there. The BSD location and the size, it is important to the left ventricular outflow component is at the ventricle, ventricular septal defect. The size and the location is a very important thing, and also recognized or preoperative diagnosis is very important in a DORB. And also, AV valve is one of the key of this one. And the papillary muscle is sometimes struggling through the BSD to other ventricles. In such a situation, we cannot close the BSDs. So cardiology echo is very important for preoperatively. Then to that the ventricular size, another important. DORB, great arteries from the one side on the right ventricle to systemic or pulmonary arteries. Other ventricles, left ventricle, usually to the little bit smallish. In such a situation, we cannot do that biventricular repair or not. So preoperative diagnosis, ventricular size, one of the key to biventricular repair. This one is a surgical outcome. It's a 380 patients with the DORB. This article from the China's. Very bad situation about this one, and the survival and the freedom from postoperative LVOTO. Much occasion to this one, non-committed BSD. Non-committed, it means to that BSD and far away from that both sides of the semilunar valves. And this table is shown as well, the subpulmonary BSD, DORB combined with that the TGA. Usually to that this one is subpulmonary BSD. Usually this one and the arterial switch procedure and close that the BSDs. And high incidence of the rate and non-committed BSDs also to the very bad situation about that high mortalities. Probably a DORB, non-committed BSD, and rerouting inside the left ventricular outflow tract very difficult. So we should do that univentricular repair. But recently the univentricular repair in the long term lots of problems. And Dr. Sakamoto showed to that whole organs failures 20 years after that, 30 years after, and then much problem is there. And also this article is very tricky, and double outlet ventricle is non-committed VSD, and far away from the semilunar valves and the trachea 45 degree or something in the inside the reroutings. Is this that good for the small babies? Probably that's answer is no. And if the trachea is tunnel from the left ventricle to aorta, sometimes lots of problem. Then after that, waiting to that left ventricle failures, like a EFE or something. Then after that, probably a transplant, just some indication of this patient. And the surgical strategy of the DORB and the very beautiful pictures I showed you. This one is a sub-aortic VSD, just beneath to the aorta. This one is the VSDs here. In the situation, subpulmonary sub-aortic VSD with the normal great artery relationship, in such a situation, close this area. That's it. Left ventricle through the VSD to the aorta. That's a good size of the left ventricular outflow tract. In such a situation, is subpulmonary VSD with transpose of the great arteries. And this one is arterial switch, and then VSD just underneath to a pulmonary artery, all ready to switch to the underneath to the aorta, then close this area. Arterial switch combined with that VSD closure, just a final decision to a biventricular repair. DORB and some specimens show too that the good pictures, anatomical characteristics and surgical procedures. The normal great arteries type, and this one sub-aortic VSD, and very important these pictures, diagrams. And this one is the right side, this one is left side, anterior and posteriors. Aorta is the right side and posterior comparing to the pulmonary arteries, and also interventricular septums here, infundibular septum here. Normal relation to the interventricular septum and the infundibular septum, 90 degree of that just closing there. That's the important anatomy of the normal inside the heart. Then original thoracic being. Original it means to that the great artery duration is a normal, but doubly committed or a little bit near to that subpulmonary VSDs, like that. And then usually to that interventricular septum and also infundibular septum, little bit wide opened, just connection to the here. And then another aspect of the posterior TGA. This one is the same situation as aorta, right side, but slightly the posterior, usually to the side-by-side arrangement, and also subpulmonary VSD. Very important to the anatomy, infundibular septum and interventricular septum are more aligned, straight line. The much different to the normal relation of the great arteries and also posterior TGAs. So I think it is important before operation or surgeon knows or cardiology knows about this arrangement. Where is the infundibular septum? Where is the interventricular septum? The angle is what degree. That is very important for also arrangement of the great arteries. And then to the normal DORB and the sub-aortic VSD1 interventricular rerouting is that much occasion to that. Original thoracic being the Kawashima, it means to the interventricular rerouting. And sometimes to that posterior TGA, very difficult to close the VSD directly, and make a left ventricular outflow tract. And then arterial switch procedure is very fitted this anatomies. Then TGA type, transposed type. Pulmonary artery is behind than the aorta, little bit left side. Aorta is anterior and right side. The name is false thoracic vein. Subpulmonary VSD, it is very close to the left ventricle through the pulmonary arteries. Then it's easy to arterial switch procedure. Then close the VSD. That's a biventricular repair. And then another DORV is a little bit artery, aorta and pulmonary artery, little bit side by side. Then interventricular rerouting and fitted through the VSD to aorta. And then this one is anatomically very difficult situation. This one anatomically corrected malposition of great arteries. Another aspect of the TGA type of the DORV. So it means to interventricular septums here, infundibular septums here, more aligned. And then much different of the false thoracic vein and SD, LDORV, and anatomically congenital malposition of the great arteries. We know that before the surgery, it is very good information for during the surgery. The patch closure of this one is the interventricular rerouting and the arterial switch procedure. Even a TGA type, anatomically corrected malposition of the great arteries, we can do patch closure of the VSDs. Then biventricular repair and is successful. And the surgical strategy on the biventricular repair, usually NGA type and the normal relation and great arteries, interventricular rerouting, and also some long patch in inside the right ventricles and the Kawashima method. TGA type on the false thoracic vein and the closure of the VSD and the arterial switch procedure. And some cases of the patient combined to that left ventricular outflow tract obstruction, like pulmonary stenosis. In such a situation, is some cases a lot of the Rastelli procedure or Rev procedure, and in some cases a Nikaido procedure. In recently, the double truncal switch procedure. But some after that, lots of redo procedure of that left ventricular outflow tract. Then some cases we do that univentricular repair. But univentricular repair is a little bit long-term outcome is a little bit come down. So our in Japan is Dr. Yamagishi creation about that truncal switch procedures. Half truncal switch procedure he established to the some articles, but not so many cases. My experience that the one case is to this one, but the patient is very good. And anatomically characteristics, these diagrams, and if that the patient has the DORV combined with that the left ventricular outflow tract, Rastelli procedure, Rocon procedure, the web, and then some cases the redo of the right ventricular outflow tract, and also some kinking to a left ventricular outflow tract. And some cases of the redo procedures, left ventricular outflow tract obstruction. Then Nikaido procedure and the truncal replace a truncal switch procedure, and also this one is a half truncal switch procedure is the same. Left ventricle to outflow very smoothly to the aorta. But that concept is okay, but operation is a very hard time and a long times. After that, some cases of that coronary first branch of the injury, interventricular septal motion is very bad. But probably a concept is okay. Like that. Then Dr. Yamagishi made this one, and the aorta is here. This one is false stealthy being type, the infundibulum septum here. VSD is far away from here. He can cut this line because of that this point, AB node. This point, left ventricle aspect, AB node. And then cut this area, no injury, no concern about that AB node. So I cut it off, this one, then switches. The surgical strategy and biventricular repair now with the DRB and some LVOTO in such a situation is a last procedure, Rukon procedure, or Nikaido procedure. And from the China is a double truncal root switch procedure. In some cases of the problems, redo procedure, even the last area and the Rukon is the old one in the long way to left ventricle to aorta. Some cases okay, but long way to left ventricles. After that, the left ventricle function is not good. And then delay presentation about this one in the left ventricle is very bad situation. So one of the very close to make a little bit shifted to that posterior is much easier to very close to left ventricle to aorta. And if the small RV and the remote VSD or restricted VSD are straddling AB valve in such a situation, the univentricular fitted. But some cases to the last steady and the Rukon and Nikaido procedure, if the patient have that mild and moderate PS, not so athletic, in such a situation, biventricular repair is one of the half truncal switch procedure is that the option to the biventricular repair. And then another aspect of that left ventricular outflow tract and biventricular repair is the TGA VSD. The impact of the length, how long to the left ventricle to aorta is fitted to the patch closure of the VSD or intraventricular rerouting. We calculated long distance from the left ventricle to aorta, not so good left ventricular outflow tract size. So which or how long to distance is much fitted, this one. And the patient undergoing a rastral type operation often require long interventricular patch. Imagine about the TGA type 3. Risk factor for the mortality left ventricular outflow tract obstruction after that. However, there is no evidence to support in the how long distance to the left ventricle to aorta. So we have that several years ago, the purpose of this study was described to the long term and outcome in a patient underwent a last stage type operation and verify whether the length of the interventricular rerouting patch really aspect the outcomes. And this one is a 43 patients in Okayama University retrospectively reviewed. A diagnosis the DORB BSD and the TGA BSD corrected trust position of BSD. And the small babies included this one, and also left ventricle function is good. Conventional continuous flow cardiopulmonary bypass, and then do the right ventricular outflow tract reconstruction, artificial valve conduit, and several right ventricular outflow tract reconstructions. And some cases of that muscular resection, all cases to the muscle resection, right ventricular outflow tract. And the one early death and the rate less than 3, and some cases are low output syndrome, and some case, one case is that arrhythmia after that. But for patient of the left ventricular outflow tract and later arrhythmia, and then we calculated how long distance to that left ventricle to aorta. And the risk analysis in the before and alive is 39, and dead the small one is 4, but tricuspid agitation and also long time operation and a close clamping time, post-operative LVOTOs and sometimes and calculated. But before operation is a small babies and not so risk factor, and the preoperative left ventricular ejection fraction is at not risk factor, and some difficult arterial switch operation is a pulmonary VSD and not risk factors. And if that left ventricle is outflow enlargement like a VSD enlargement, not risk factor about that this. And the length between IVS and the aortic valve are like that. If that what size we measured this size left ventricle to aorta, some big distance of that some risk of the left ventricular outflow tract. We lots of measuring about the body weight and the BSA and the normal aortic valve size, but more significantly good for predicted to the normal LVDD to the length of the AV valve to interventricular septum. And then we calculated that again to the group A, IVS to aortic valve length and less than 80%, and length to that more than 80%. We check to that. Long distance of that left ventricle to aorta is one of the risk factor of the death because of that left ventricular outflow tract obstructions. And then a little bit long time operation, but outcomes is much better to that short length of the left ventricle to aorta. And
Dr.
much different.
Kindly come to the conclusion.
Okay, concluded. Okay, sorry about that. So estimated cardiac survival-free event is here, and the effect of the large RPDP group P, and also limitation conclusion is just calculated, and the length of that IVS-AV length found to be the significant risk factor. Thank you very much for your attention.